Good afternoon, everyone. Welcome to this meeting of the Health Overview and Scrutiny Committee. This meeting is being broadcast live to the public via YouTube and will be available for viewing on the YouTube channel after the meeting. Please turn your microphone on when speaking, but please remember to turn it off when you've stopped speaking. Otherwise, the system gets a little bit confused. So if you can just remember those 2 points, that would be excellent. We are all present apart from Mr. Pendleton, who is due to join us. I'm not entirely sure whether he's running late, so perhaps we can record him as absent if he doesn't actually manage to make the meeting at the end, but he was due to be here. So otherwise, I think we're all present and correct without any substitutions. So I'm going to start going through the agenda, if that's okay. Item 1, minutes of the meeting held on the 14th of June 2023. Is everyone happy that we accept those minutes as true and accurate record? Okay, that's great. Thank you very much. So we'll accept those. Item 2, question time. So we do have a couple of questions from members of the public. We've got Juliana Foster, who I can see in front of me now. Good afternoon, Juliana.
Hello.
You've asked a question regarding health services in Lutterworth. This is an item that we are also taking on this agenda, so by all means, there's an opportunity for you to ask a follow-on question in a couple of seconds. And we also had a question from Rachel Hall from the Falcon Centre, Falcon Support Services, regarding homeless review. Again, likewise, this is an item that's on the agenda, but we'll come to the questions in a couple of seconds. So the questions have been asked and answers have been provided. Those answers have been published on the council's website, but they've also been provided to the two questioners. What I'm going to do is ask each Juliana and also Rachel whether they wish to ask any supplementary questions. I would say to both of you, the supplementary question should be to clarify the answer given in the original questions, and it shouldn't introduce any new matter which did not fall within the scope of the original question. If you do want to raise anything that's outside of the scope of the original question, you are most welcome to ask an additional question following this meeting, and then obviously that can be answered in a similar way. But if you could restrict your follow-on supplementary questions to the original question and the answer provided, that would be good. So Juliana first, can I ask you if you wish to ask a supplementary question in relation to the question that you submitted and the answer you've received?
Thanks, Chair. Yes, I would like to ask supplementary questions, please.
Okay, if you'd like to go ahead.
Right. My first question, the ICB have stated in their answer that the current plans for Field and Palmer Cottage Hospital have been developed on current evidence of need of the local population. Now, given that the percentage of respondents to the last 3 public consultations, which was Building Better Hospitals, mental health and GP practice, the respondents from the LE17 area was as low as 0.3%, 0.4% and 0.2%, which is hardly representative of the area. So could I ask where else the ICB has gained its evidence to develop the plans for the Lutterworth area, please?
Okay, should we take all the questions? Because I suspect that probably we might need to ask the ICB to actually come back and answer any of the questions that you have, rather than necessarily directly at this meeting. But do you have any other following on supplementary questions? Okay, if you just run through all of those, that'd be good. Okay,
and then on the second point I made, the answer that the ICB have given me is they're talking about enhanced procedure suite, and there are 6 consultation rooms. Can I ask for clarification, please? What exactly is meant by the enhanced procedure suite? And will the 6 consultation rooms, are they to be used only for the proposed outpatient clinics, or has the Trust got other services in mind for their use or combined use? And if so, what are they? Thank you.
Okay, we've noted that one. If you want to move on to the next one.
Okay, and number 3, again, the ICB answer to my question states that a wide range of specialities and procedures they have identified that could be delivered from Fielding Palmer and not can be delivered from Fielding Palmer. So again, what assurance can the ICB give to this scrutiny board today that with a degree of flexibility, which I understand they will require, that the outpatient diagnostic clinics will be instated at Fielding Palmer in view of the recent extensive development plans for diagnostic and outpatient services at Hinckley and Market Harborough.
Okay, thank you. We've noted that one. And have you got a final one?
Yes, one last one. Again, it's to do with the funding. The £5.8 million that the ICB have identified that is required for the refurbishment of Fielding Palmer. How confident is the ICB that they will be able to secure this money, this capital, given that the funding for the Hinckley Community Diagnostic Centre was dependent on it being demonstrated that the scheme would result in extra capacity and at Hinckley and not result in less capacity elsewhere in Leicester, Leicestershire and Rutland? And will the plans for Fielding Palmer have to meet the same criteria as Hinckley did in order to secure the funding? That's it from me. Thank you.
Okay, thank you very much, Juliana. That's great. Look, what I'm going to do is we've got partners from ICB listening in on this. I'll ask them to address those answers to you. I suspect because of the detailed nature, probably they may need to actually go away and actually research some of those answers, and they can come back to you. We obviously do have a session, an item 9, which is coming up on the agenda. If any of those points can be, we'll hold them obviously open. If any of those points can be answered by the ICB under that item, then I'll encourage them to do so. But otherwise, I'll ask that they provide a written answer, and we'll pass that over to you as soon as we can. So thank you very much for asking the supplementary questions. And that's very kind of you. And thank you very much for joining us this afternoon.
Thank you. Thank you.
Thank you very much. Okay, we now move on to Rachel Hall from the Falcon Services. Rachel, are you still on the line? I think you probably are.
Yes, I am. Thank you.
Thank you very much. Sorry, Juliana, is it possible to actually turn your camera off, and then we have then just one image on the screen in front of us? That's lovely. Thank you very much. Okay, Rachel, we can see you now on our screen in front of us, so that's great. Thank you very much for joining us. Similar point, obviously, about being able to actually ask supplementaries which relate to the original question or the answer provided. I understand that you have a few supplementary points, so if you want to actually raise those in one go, that would be great. And then I can ask colleagues in the room to either answer directly or alternatively, as I said also to Juliana, we can take them into the scope of the agenda item itself. So I'll pass over to you now.
Thank you. And I'd just like to say thank you for the comprehensive responses that we have received. In relation to question 1, where it mentions that support is linked to accommodation and is not part of the accommodation. I just wanted to clarify that we do understand that current funding doesn't pay for the accommodation itself. The accommodation is paid for by housing benefit under the exempt accommodation rate because of the contract from Leicestershire County Council around the support for this client group. I think our confusion has come about following these statements, following the service spec, and would like some clarification from where it says it is only linked to accommodation. There are a number of other statements that have led us to infer for the last 10 years that it has included accommodation. Things like hours of operation for supported accommodation is 24/7, 365 days a year, and we must employ all staff required for safe running of supported accommodation, and the hostel premises must be compliant. So it'd be really useful to get some clarification on where it is only linked to accommodation. That was my first question. The second question was linked to question 2. And the question asked around impact assessment, and the response is around the equality impact assessment. And I would just like some clarification whether an impact assessment has been conducted around decommissioning this service to look at the wider implications of this proposal, as opposed to the equality impact assessment, which I appreciate has been done and has been shared. Point number 3, or question number 3 that I had, was just regarding to where it says that Falcon Support Services solely deal with housing issues, and I would just like to clarify that that is factually incorrect. We deliver a really comprehensive supported accommodation service. We offer a wide range of services, including health and wellbeing initiatives, substance misuse and mental health support. And I think I have submitted various reports to demonstrate that, and we have had various audits. So I think that probably could be clarified as to what we do deliver is not just housing. So it's more of a statement rather than a question, that one. With regards to the service users feeling they didn't have a voice, I'm really pleased to see there's been such a large response to the survey. And I think that has really been down to the commitment of the staff in helping people to fill in the surveys, but also Leicestershire County Council making changes to make the survey more accessible. So we could then access it via shared computers. We didn't have restricted word counts and issuing paper copies, so I'd like to thank Leicestershire County Council for doing that. However, they were muted, our service users, in the information session, and I would like to clarify that there have been 0 face-to-face focus groups held with this client group following the model being proposed. So the clarifying question is, if there have been face-to-face focus groups with our service users, is there any evidence of this? Because we are not aware of any of this from our client group. We did offer and did request for public health to complete face-to-face focus groups with our client group and offered the facilities to do that, but were unfortunately turned down. And finally, on the last point, I just want to clarify something around this proposal. So we've been told all along that these funding cuts are due to inflation and a need to save money for Leicestershire County Council. And I appreciate that is a factor, but could it be clarified what the additional factors are for reviewing the homeless support service, and how has it been established that the proposed model will better align with the duties of the council and local need? Thank you.
Thank you very much, Rachel. OK, we've got Mike and Sally here from Public Health, so hopefully they can help to answer some of those points. And as I said, there's an opportunity later on in the agenda item for people to ask further questions on any of the answers being provided now. So, Mike, do you want to take us through some of those?
Do you want to do that now then, or rather than wait?
Yeah, I mean, by all means, if you want to do that now, and then
sure.
We'll then take. I know, Rachel, you've got I think a couple of minutes during the main agenda item, so a few extra points. So that's an opportunity then if you want to come back on any of those points as well.
Not then we can answer all of them, and as Rachel said, I think there's 4 questions with a statement, which is fair enough. One, I mean, it's never been confusing to me, but I mean, maybe I can understand why. There are a number of requirements, as Rachel's pointed out, which we've alluded to in our response around the service specification and the standards and the statements that have been included in our answer. They are all, they are not that we want to commission ourselves. They are all the requirements that we require. Let's get my words right. Go back to basics. What do? We commission a service currently composed of an in-reach component and a community outreach component. The current service provider is that combination of Falcon Support Services and Nottingham Community Housing Association. Like any other contract, we would specify for the inReach the requirements and the standards that we expect of the facility within which that is provided, if that makes sense. So the obvious one would be, I think there's probably a statement in there to do with complying with every building standard and regulation. That's not that we would fund a building to get to that level. It's just obviously if you're going to deliver a service in there, it needs to be up to scratch. Same when we say it needs to be 30 units of accommodation. Yes, it does. That can be one single hostel in the Falcons case. It can be, or it could be, if another provider had bidden one for it, a combination of hostels. But it's almost, you're setting the requirements for what you require from the setting in which the service you are actually delivering needs to meet, if that makes sense. Question 2, equality impact assessment. Yes, we've done the EIA, which is an iterative process. My understanding is there's no requirement to undertake an overall impact assessment as such at the moment. Clearly, when we go to Cabinet in November with the results of the consultation, of which this afternoon forms part of that consultation response, we would need to include alternative proposals in there, which I suspect should take account of the overall impact on there. So we can't just say, we just do this, we'll make it. So it's a bit of a fudged answer from me. So the answer is we haven't done a formal IA, but actually the impact would be something that Cabinet need to decide going on, and we need to address that with alternative proposals to flag up the impact more generally. Question 3, I think, was a statement. Question 4, face-to-face. Yeah, I think we did formally. Just to respond to this comment that service users have been muted, though, the intention was never that was a consultation session as such held online. It was more like a webinar to give participants additional information that they could then go and fill in the response questionnaire, including, as Rachel said, the ones that the Falcon Centre very helpfully received from us to sit down with service users. So I think the answer is we probably did not do a formal face-to-face session with existing service users, as I think Rachel interprets it. I do bridle at the use of the word muted people's voices when, like any webinar, as you know, you receive the information and then you give your responses outside. And 5, what would we add? Yeah, I mean, it's always worthwhile. I mean, you know, Rachel alludes to the financial position, and there's many and varied. It's not just the medium-term financial strategy, but also the cost pressures on the public health grant through NHS pay awards, etc., etc. So we are under financial strain. Of course, it's always good practice to not so much review a service as we would do through our contract management meetings, but also to think about what it is we need to provide. And again, coming almost leading on to the paper, there is something for me about going back to first base and thinking, what do we do? Well, we, as a county council, we have no duties under housing regulations. We do have a duty under public health regulations to take steps to improve the health and well-being of the population. Within that, the homeless population is an important one. As we point out in the paper, their life expectancy is 30 years less than the average. I think some of those other factors really are reviewing things like, are we providing that health improving service to that particular cohort of the population across the county in a consistent manner? Even if we had the same budget as we did have, are there more efficient ways of doing it, which means we are funneling people, are we joining up our particular services in First Contact Plus, local area coordination, the substance misuse service, with district housing authorities? So I think there probably are a range of points that we have reviewed, particularly on the back of not the service review, but the piece of work that we did sort of 18 months, 2 years ago, which basically is not so much about the quality of the current service, but of course there's always a chance to review are we doing all we can do in the most efficient manner possible to reach people in the most efficient way that we can. Now, that's not to say that Falcon Centre aren't, but you know, every day is an opportunity to review and reflect on what we do.
Louise, do you want to add any answers?
Yeah, just about the service users being muted, etc., and no face-to-face groups. There were some face-to-face groups arranged at Loughborough Library, which I attended and which Vulcan users did attend. So there has been face-to-face discussions that have gone on. Thank you.
Thank you very much. Okay, thank you very much for those answers. As I said, we'll pick up any additional points during the main agenda item itself, and Rachel will have an opportunity to say a little bit more during that session as well. So I'm going to move on to item 3. This is questions asked by members understanding order 7375. We have received 4 questions from Mrs. Page. Regarding Lutterworth Health Services, Mrs. Page has been provided with written answers, and the answers have been circulated to the committee and published on the website. Mrs. Page has confirmed that she does not wish to ask a supplementary question. So item 4, to advise the chairman of any items which are decided as urgent elsewhere on the agenda. There are no urgent items. Item 5, declarations of interest. Are there any declarations that anyone wishes to raise? Mr. Newton, we will absolutely take that as standard. I feel as if I know your declarations before you're even going to say it. So thank you very much for raising it, though. No other declarations. Mr. Seaton.
Thank you. I understood that completely. I'm a member of the CCG in Silverdale Surgery. Thank you. BPG, sorry.
Thank you very much. That was a bit more intelligible than my babble, but thank you very much. Okay, no other declarations of interest. In that case, item 6, declaration of the party whip in accordance with review and scrutiny procedure 16. Are there any declarations? I don't think there are. No. So item 7, presentation of petitions under standing order 35. No petitions have been received. So we're now on to the main 3 items of the agenda. Item 8, review of homeless support service. We have obviously Sally Valance and Mike Sandys here with us, and also lead member Mrs. Richardson. So I'm going to ask Mike, who's our Director of Public Health, is going to introduce the report. Likewise, we always accept reports as read. So there's an opportunity to take sort of up to a couple of minutes to raise or draw attention to any particular items within the report. Once Mike is finished, going to ask Rachel to come back online, and also likewise to raise or flag any points, again, no more than a couple of minutes. We'll have an opportunity to ask any questions of Rachel at that point before we then move on to the main discussion item, or the main discussion of the item itself. So Mike, over to you first.
Yeah, thank you, Chair. I think I probably largely covered some of what I was going to say in the remarks in relation to the supplementary questions. I will take the paper as read. Obviously, it sets out the need to review what we currently do in terms of specialist health improvement within the homeless population, driven by the medium-term financial strategy and the need to release a saving of £300,000 within that, which is the total of the current contract value. The main part, and again, I suppose there's 2 bits. I've said at the start, it's important to remember that this is a commissioned service. So although there may be, and I'm happy to take questions as to the points, some of the points that Falcon have made outside this meeting, this really for me is about moving from a specialist model where support is provided to this cohort within a hostel-based accommodation and within the community to offer advice around health improvement, plugging in to services like Turning Point as our substance misuse provider and our broader services, warm homes, etc., to one where we do that through our existing universal service, of which there's 2 things. There's First Contact Plus as our largely digital front door, if you like, to a range of services which are listed in RAF 17. And then also through the use of local area coordinators. I think many of you will be familiar with the work of local area coordinators, which would provide that person-to-person link between that cohort and, again, gateway and access to our range of services. As I kind of said in the introductory comments, I think that gives us an opportunity to think through how, for instance, local area coordination and First Contact Plus work more directly with the district housing authorities who do have that responsibility around housing, and make certain that anybody that comes within the purview of district housing, whether they're eligible support from district and borough councils or whether they don't, are kind of passed on to us, so we can provide that same provision or the same signposting and referral mechanisms that we do at the moment. So largely the proposal is as per paragraph 14 onwards, in terms of moving from that bespoke commission service to incorporating it as part of what we would provide for everybody, albeit making certain that we're not just providing a web-based thing. We are thinking about how do we engage with what is a vulnerable cohort of the population. So I'll leave it there, I think.
Thank you very much, Mike. Rachel, if you're still there.
Hi.
Hi there. So can I ask whether you would like to add up to sort of a couple of minutes of points in relation to the report? That would be good as well, and then we can ask any questions of you afterwards.
Thank you. We've had a really long-standing good relationship with Leicestershire County Council over the years, and operated contracts on behalf of public health and adult social care for a very long time. And we do understand the current contract is due to end on the 31st of March 2024, as many contracts have done before. And we understand the review of services, the consultation, the retendering process that goes on. However, we didn't expect there to no longer be a dedicated commission service for this particular vulnerable cohort. Historically, consultations have felt objective and open-minded, whereas this format has felt very, very different. The public made their views clear on the mid-term financial strategy consultation that their number one objective on cost saving was community wellbeing, safety and homelessness. And from the report, I've noticed that the preliminary findings echo the same, that they strongly disagree with the proposed new model. We do feel that Cabinet members have been provided with inaccurate and at best misleading information, and there seems to be little work that's been completed on the impact of these funding cuts or the viability of the proposed model. We would like to have an opportunity to work together with all parties involved, districts, health, adult social care, public health, so that we can try and find a resolution to protect vital services, because we have serious concerns that the most vulnerable will suffer through this generic digital service model. We do work closely with First Contact Plus and local area coordinators, so this proposal will reduce what they currently receive. And I do feel that Leicestershire County Council will incur longer term financial costs for the short term savings that would be gained. And I'd just like to thank you for allowing me to attend today's meeting and for your time and listening to me. Thank you.
Thank you, Rachel. So I'm going to ask whether any of the committee members have any questions directly to Mike, if you want to go first, Mr. Charlesworth.
Thank you. Rachel, how long have LCC been providing a financial contract to Falcon?
For the actual Falcon Centre, 10 years ago. It was commissioned 10 years ago, including the renovations to the building to deliver the accommodation.
Okay, and in your letter you sent out to members prior to this meeting, which I've read, it states without this 300,000, the Falcon Centre may have to close.
That's correct.
That is correct. What proportion of that 300,000 was of your total budget?
It's a relatively small amount, but the challenge is that the £300,000 and having the support contract enables it to be classed as exempt accommodation by housing benefit, which actually means the total comes to just under £1 million.
Okay, thank you.
Thank you, Mrs. Newson.
Chair, being from Shepshed, but doing a lot, my ward is in Loughborough, so I'm very well aware of the work that the Falcon Centre actually does. But I'm sure most of you would have received a paper also from Homeless Link, where they outlined the fact that the number of people sleeping rough in Leicester and Rutland has increased by 109% between 2021 and 2022. This means we have had more than a doubling according to the statistics, which is 4% on the national average rise. This was analysis done by Shelter, and it showed that an estimated 1,400 people were homeless across the county on any given night in 2022. And I understand this figure includes both those sleeping rough and those living in temporary accommodation. The council stated that the end of the homeless support would not lead to the closure of the Falcon Centre, but I personally am not convinced that that's correct. Being a councillor from Loughborough, I'm well aware, as I said, of the work that you do. This worries me because it could lead to more people being homeless and sleeping rough.
Ms. Newton, sorry, is this a question for Rachel?
Oh yeah, well Rachel, my question is, I just wanted to know whether or not you consider that we have actually taken on board all of the points that you needed to make.
I certainly feel like I've had the opportunity to raise my concerns and questions. So thank you for that. I do, particularly the part where I said about, I feel like it's been inaccurate and misled. That was the initial cabinet paper that said this contract will have no impact on the hostel. It has a direct impact, and I think that is misleading to cabinet, who are making really difficult decisions in this time.
Okay, thank you very much. We'll come on to any discussion points, obviously, later on. Are there any other questions? Mr. Harrison.
Good afternoon, Rachel. I'd like to put a thought into your mind that reading the report, it states that the service is underutilised due to the slow move on service users. I experienced a comment when I visited the centre a couple of years ago and was shown bedrooms and met one young gentleman who was keen on bodybuilding, etc., etc. And I was enthused by his attitude and suggested that, you know, what's happened, where are you going next? And he said, oh, no, I'm nowhere near ready for moving on. So what I'm trying to say is that 300,000 looks as though it's supporting just 30 people, their accommodation. So from a distance, looking at how it's utilised and what we're talking about, it is a significant amount of money. But I sort of thought originally when visiting the centre, it was something that somebody may have for a few weeks, a month there, but it would appear that there's sort of quite long-term attitude there. So you have to class what is homelessness, you know, is it temporary, is it this, is it that, and what other provision? Because really it would appear that probably that 300,000 is just used for one element of that and not generalising the benefit of all the homeless people. So it's quite pointed, because if it's only supporting 30 people, it's not talking about Mrs. Newton's percentage growth of people. Other people aren't allowed to have a chance because that's how it is. Thank you, Mr. Chairman.
And is the question to Rachel in that case about how many people does it support?
Indeed, yes, thank you, Chairman.
And I think this is where we also feel it's been misleading. We support 30 people at any one time. That is consistently 100 people a year that live at that project, that we move on, not even just to local authority and housing association, but to private rent and other accommodation that we have, which keeps the throughput going. So it supports a lot more than 30 people. It supports 100 a year, and the statistics show that. We deliver supported accommodation, so it's not a really short term. It's not about sticking plaster on homelessness. It takes a lot of trauma to end up in a situation where you're homeless. And so there is a lot of support that goes into someone when they are with us, working with other providers. And that does take time. Our average stay is about 4 months. What I would just say is, with regards to the underutilised, it is full 100% of the time, and we operate a waiting list because we need more bed spaces, not the closure of 30 bed spaces that accommodate 100 people a year. Thank you.
Can I ask one more question in that case? So I'm aware obviously of Falcon Centre, but also the Carpenter's Arms that operates at Six Hills. Apart from the Carpenter's Arms and the Falcon Centre, how many other homeless sort of accommodation centres are there in Leicestershire?
In Leicestershire, from my understanding, there is Xavier Trust that has a model, and Action Homeless have a few bed spaces in Hinckley. There's Hinckley Homeless, and there's Emmaus, which is also, I think, correct. I might be wrong, but I think it's a rehab type facility as well, helping people with treatment.
Okay, and the Carpenter's Arms, I think, is probably
rehabilitation as well.
Yes.
2 or 3 times the size as far as bed spaces of Falcon.
Falcon Centre is 30 bed. Yes, they do have more bed spaces. Yeah, as an organisation, we have 100 bed spaces. But as that particular project that this contract sits over, it's 30 bed spaces.
Okay, thank you very much for that, Rachel. Okay, I can't see any other hands up, so thank you very much, Rachel. So if I can ask you to brilliant, you've turned your camera off before I was even going to say anything, so thank you very much, Rachel, for that. What we're going to do now is move on to discussion of the paper itself. So if you have any questions for our public health team, by all means, please raise your hands. I can see Mr. Charlesworth to start off with. Okay, if you want to start.
Thank you, Chair. Just a quick one, really. Your glasses on. Item 29. Is there any flesh on the bones of the new offer that's proposed from the 1st of April?
Yeah, that's what's set out in between paragraphs 14 and 19. So the new offer would be the use of First Contact Plus and local area coordination.
Okay, thank you.
So I know Milo, who I think is our sort of first contact or area coordinator in Loughborough, who is sort of been working in the town for quite a long time. Who I have to say is a very impressive individual, and I know he was. I'm assuming he'll be one of the point of contacts that we're referring to.
Yeah, well, yes, they would be. I mean, again, talked about First Contact Plus. So, I mean, to put a bit of flesh on the bone. So, First Contact Plus is largely an online, public-facing bit where people can get in contact and then receive a telephone call back to take people through kind of strengths-based needs assessment, refer them to appropriate services. Clearly, there'd be a concern from people that would not be totally appropriate for the homeless population, given their online stuff. So First Contact Plus does receive telephone referrals from professionals. So when I talked about a better link with all district housing departments, then if you imagine what Milo does in Loughborough, having those links in with every district and borough council housing thing to provide that link as First Contact Plus with the existing housing thing would be, to my mind, one way where we could take what we probably do with the Falcon Centre through Milo and then actually extend that reach into the homeless population throughout the county. Again, be the first to recognise that Falcon doesn't just serve Loughborough, but clearly there's a there's a representation from the local area, which makes me think, is there a way of doing this which actually gives a fairer equity across the rest of the county? But the way you describe Milo work in your area is exactly what I want to see, as they do already with other cohorts, work through local area coordinators elsewhere.
Can I follow on one of the questions before, if you don't mind, before coming on the question? So I know that in particular, in relation to provision and refund of sort of costs to homeless provision within the area, you're talking about the cohorts, the homeless cohorts within the areas. And I know in the Charnwood area in particular, there has been a sort of long-running sort of lobbying campaign from the district authority in particular in relation to the covering of costs, where providers are not covered by SLAs, and therefore actually the districts end up having to pick up directly the costs rather than actually being refunded by national government. And that's particularly for those areas that are attracting residents to those centres from outside of the area, not even Charnwood or Leicestershire, but sometimes nationally. And a lot of districts where there are sort of a small number across the country that I think have high numbers in relation to their sizes of centres that are obviously costing a huge amount of money. In Charnwood, I mean, one of the projected figures was close to £1 million a year of costs that were not going to be able to be charged back from national government to actually provide places. Do we actually know how many of the people within the Falcon, but also Carpenter's Arms and elsewhere, how many of those are actually from Leicestershire, and how many that are actually beyond the county boundaries? Because obviously that's quite a significant number, I suspect.
Not with me. I know I saw data around where Leicestershire residents in the Falcon Centre came from in terms of the boroughs. I couldn't say off the top of my head. I don't think Sally knows either exactly what the split is in terms of out of county and in county figures.
Okay, no, it was just a question out of interest, because obviously it's you know, the way that it's structured nationally, I have to say, is as ever with many national government things, is not necessarily advantageous to the workings of local government, whether it's at county level or district level. And I suspect this is probably one of those where changes many years ago were not necessarily thought through thoroughly as to the implications of how they would actually be worked on the ground. But okay, that's helpful. Mrs. Newton, do you want to ask a question, and then we'll come on to any others?
I think that I think I am personally concerned about the number of people sleeping rough, not just in Loughborough, but all over Leicestershire. And I think it's increasing. And I got some statistics by 109%. So it's more than doubled between 2021 and 2022. And I think it's on the rise here. It says, is it 4 times the national average or something like that? So there is a very big concern. And indeed, from shelters also raised the fact that homelessness across the county on any given night is very high. But it includes not just those sleeping rough, but also those in temporary accommodation. So it's very hard to extrapolate, you know, those who are rough and those who have accommodation. I know the council stated that the end of homeless support would not lead to the closure of the Falcon Centre, but I'm not convinced that's correct, because they really need the county money to carry on. And it's not just homelessness, it's poor health as well. So they're actually sort of having to use other services more than most people. And I think too, we have a number of very vulnerable people who really lack any type of services they need to really make the better of their lives. So I just wanted to wonder if we could really take on board the implications, full implications of the proposals to shut down the Falcon Centre. I have, as I say, I have serious concerns. Thank you.
Okay, just for clarity, the county council is not shutting anything down. I think this is about
it's a funding.
This is about a consultation on.
Sorry for the
on the consultation.
Wrong wording.
Okay, Mike.
So just to pick up a few points, which actually also came out of what Rachel was saying. I'll go through the money first. So there was reference earlier on to £300,000. That's the totality of the contract. And as I said at the start, that's split between in-reach and community provision. It's split between the community provision, which is provided by NCHA, Nottingham Community Housing Association, and Falcon Support Services. Within that £300,000, there was originally a third provider who provided a referral hub. They withdrew from the contract and Falcon picked up that element. So essentially, although the figures are a bit malleable, if you took out the NCHA proportion and the referral hub proportion, the amount that Falcon Support Services receive from the contract which they won in partnership with others 3-4 years ago is near £140,000. In terms of where that money goes, that funds a number of staff, probably around 5, which with on costs, you know, so again, we are not funding beds. So looking at you, Mr. Harrison, we're funding the staff that provide the support service, because that's a health improving support service. It is not a homeless accommodation. It's also important to remember, given a couple of comments have been made, to refer back to my original comment. This is a commissioned service. We do not directly grant fund the Falcon Centre or Falcon Support Services. They won the last contract. If we went to Cabinet and this proposal was keep it as it is and we went out to contract again, it is entirely plausible there are other providers, because Rachel has said herself there are other hostels within Leicestershire that may come together as a consortium with community providers, may come together as a consortium of other hostels, and they might win the contract. So if the questions that have been put to you today were, if we don't win this contract, we'll have to close, I suspect we'd be having a very different conversation. So some of the questions about will there be an impact, there are two answers in my mind. Well, there might be an impact if they don't win the contract, if we didn't change the service. But what would they do then? So if there are underlying issues with their finances, then frankly, that's an issue for the Falcon Centre to respond around their finances. It's not about the proposal. Obviously, over the months, I've probably got to know far too much about the workings of the Falcon Centre and homeless and housing. And, you know, homelessness is the big issue. I wouldn't do it, but it's not the public health job to provide homeless hostels. It's our job to improve the health of the homeless, which we are trying to do in a different way. There are various things to do with the makeup of the Falcon Centre. Other hostels, Exario being one of them, are registered social landlords, which my understanding is now allows them to claim housing benefit directly from the government. So your point, Mr. Morgan, about top-ups from Chelmsford Borough Council, etc., just doesn't happen. So all this conversation about if it's not so much the direct money, but actually if we lose this, we can't claim housing benefit. Again, you know, to be blunt, I think there are questions there for the Falcon Centre to answer. It's not my question, which is, why have you chosen not to be a registered social landlord, but you are using this top-up? And even then, there are further questions along the lines of, for Chelmsford Borough Council in this case, where they say it requires an additional number of hours of support to enable them to claim that. Why have they set it at the level they have done? And I would still say, coming back to our service offer, our other services, Turning Point is a classic case in point, also provide drop-in sessions into the Falcon Centre regardless of this bespoke contract. And so again, I think there's a whole unpacking outside of the proposal around this model, around what is also provided in the Falcon that may or may not enable them to claim this additional housing benefit from CBC, and also the, you know, the finances. And it is, you know, and I've got to leave it there because it is not a question about, it is not a session about the Falcon Centre. But I suppose I do bridle that somehow that we will, you know, that that this funding will be cut and they will close. Well, I think there are questions about will they really, in which case it needs a different conversation with partners. And again, it comes down to the commission service bit. If it's a commission service, they might not win it. So then what would they do? And I'll leave it there for me, Chair.
Okay. Thank you very much. Can I ask one question actually? And this might be for Councillor Richardson to support answer on as well. So I mean, very interesting, Mike, your comments there, in particular about the commissioning of services, and it's really just understanding how the county as an organisation audits how those services are being provided over the duration of the contract. I mean, there seems to be, as I said, you know, Rachel's outlined it, you've outlined it, and a different interpretation of what's being commissioned and the impact of that commissioning. Now, your description is very clear, which is, you know, that there is a requirement as far as sort of you know, we will commission as long as you as an organisation provide X, Y, and Z, and we are commissioning a range of services, originally from 3 providers, now 2, and we expect this provision, and therefore the cost will be Y. And my question is, given that at the end of the contract, and this is not unusual at the end of a contract, to be frank, but you know, hopefully everyone gets an opportunity to learn, which is how can we actually stop this being a problem in the future by making sure that, you know, the clarity of the contract, the way that the services are audited on an annual basis, etc., means that those misunderstandings of what the commissioning was supposed to be for, what the payments that we're actually giving to a third-party organisation are being used for, so that when we actually come to the end of the contract, we are not in the same position of, to be frank, you know, an alternative viewpoint being put to the one that you've expressed very clearly as the understanding from the County Council's position.
I'll start. I'll probably bring Sally in as well. I've forgotten where I was going to lead off. Bear with me. Do you want to do contract management meetings whilst my brain fires up?
Yes, thank you. Just to explain our processes around contract management and how we oversee our suppliers for our services, we have a quarterly contract management meeting with all of our organisations, so that informs us and them of any changes that are happening, any issues cropping up for either party, and gives us an opportunity to talk through the provision and how the service delivery is going. So as I say, those happen quarterly. We also have performance indicator information, so we ask for data from our providers, again, usually on a quarterly basis, depending on the service, but most often on a quarterly basis. That would detail things like who has used the service, the current caseload that they're carrying, perhaps things like length of time that people are with the service for, and the sort of outcomes that they achieve or don't on exit of the service. So we've a good way of managing our services in place, but of course always happy to build on that and look at ways of improving that. Again, as Mike has said, at the end of every contract, it's routine for us to look at that again, to do a review, to look at the specifications, so the paperwork, the contract that comes with that, and again look at whether that is current, whether there are new issues that need to be covered within that, whether there are tighter ways of ensuring that service is delivered in line with what current need is within our population. So again, all of those would be reviewed and would offer opportunity to tighten up whenever we're letting a new contract.
And thank you, Sally. I've reminded myself of that, because I suppose the other important bit is, coming back to your point about money, Mr. Morgan, is, obviously we don't commission in such a way that says, right, we're going to give you this amount of money and you're going to spend it on X, Y, and Z. Essentially, the KPIs that Sally's laid out, here is the budget, here are your KPIs, you tell us how you're going to do it. So that's the other bit. So we wouldn't necessarily specify that we would determine every single A, B, C, D, dotted I, cross T, in terms of what the contract would do in terms of manpower. But in terms of the KPIs and the way we do that, Sally's covered that very well.
Thank you very much. Mr. Hall.
Thank you, Mike. Actually, you've answered a lot of the questions already. I was just curious, this £300,000 contract that we've most recently given them, how long was the contract for?
So last time we did this was back in 2019, so it's been a 3+1 contract. For what it's worth, that I was going to mention this at the end, but the history of this is the last time we considered this, we actually tabled at Cabinet for consultation a very similar proposal. And then actually when it went through consultation, Cabinet decided not to go through with the proposed model change. So again, to pick up an implication, I think, that was said earlier on, that this was somehow a done deal and we've misled Cabinet, words of which I do find upsetting, to be honest. We've been here before, consultation ran its course and Cabinet decided contrary to what I put forward. So straight answer is 4-year contract, 3+1, but I think the history of this is quite important too.
And if I could have a follow-up question, it's on a slightly different matter, about the local area coordinators. They're doing an absolutely fantastic job in my division, and I'm fortunate enough to get an update from them every couple of months or so, outlining the work that they do. Is it right in saying there'll be an increased number then of these coordinators in Loughborough? So I think I have 2 in my division, which if we're looking at a larger homeless population, I presume they'd need more.
No, it would be, don't forget, it's just not just Loughborough, because for me it's about making it consistent across the county. Now we've got, in one way, shape or form, county-wide coverage of LAC. It's moved on from the early days when we used to have about half a dozen to, we now have the biggest local area coordination team in the country, which is about 35. But this, obviously, because of the need for savings, is essentially an extra workload on local area coordinators and first contact planners.
Sally and then Mrs. Richardson.
Sorry, I was just going to mention as well that because our local area coordinators is a reasonably large service across Leicestershire, it does offer us that flexibility. So if there is a need to kind of move some of that resource according to need in the population, then we do have the flexibility to do that within the service.
It's Mr. Richardson, and then we'll come back to you, Mrs. Newton.
Thanks a lot, Chair. I have to say the local area coordination team are working absolutely fantastically. It's actually been recognised nationally, and we may have a minister coming down at some point, and great interest from other areas. And they work very well within the communities. I think we have to remember that this proposal is very much to have consistency across the county, to provide a wider benefit to people. It's not just for priority, it's trying to get the help there before people become homeless, before people have real struggles in life. I think we also, some of the provision at the moment is a short-term setup. This would be supporting people for however long they needed it, and they would also be monitored more effectively through ensuring that they are actually receiving what they're being signposted to do. I think my question is really where is the sustainability for Falcon House as a charity? Because I run my own charity. We all know that there should be risk assessments and checks on if you don't have a grant come in or you don't have a commission service come in. To turn around and say, well, you know, reviewing this commissioning and somebody else may be getting the, you know, the provision coming back in-house, I would be asking, well, where has been the review of finances to ensure that they could continue? And I also question not being a social landlord. I have spoken to other providers where this has given much more independence to providers and not a burden on the local district councils. And finally, you may be slightly upset about the misleading information going to Cabinet. I'm a Cabinet member. I see all reports that go to Cabinet. I work very closely with Public Health, and I do take a bit, that's rather offensive. Thank you.
Thank you very much. I absolutely understand the point about Cabinet members. I have to say, having been a member of my own Cabinet elsewhere for over a decade, I can guarantee Cabinet members are free thinkers, much to the frustration probably of officers sometimes. But the word done deal and cabinets, I think, is an absolute misnomer. Councillor Newton. Sorry, Mrs. Newton. Sorry, apologies.
Just call me Councillor, I prefer it. I just wanted to say, you touched on local area coordinators. I have to say, and it's one of the best things we've done. And I've had a number of meetings with the one in my local area, and all been very positive. So I think I'd like you to take back to your Cabinet how well that, well, where I am, how well that is working, and thank you.
Absolutely support that. As I said, Milo, who I deal with on a sort of occasional basis, has always been very impressive. Okay, we've run out of questions, so thank you very much. I think, look, there are a collection of points that I know Ewan will be summarising for Cabinet. This is about inputting in on consultation. Mike, you're going to say a couple of points.
Yeah, so you may just be about to beat me to it, but just to remind the Scrutiny Committee, as per paragraph 25, today is about your views of the proposed new model. So the comments about lack are very well received. We're coming back in November for a fuller consideration by Scrutiny of the consultation response to the same. Sorry to be
would you like to chair this meeting, Mike? That is exactly what I was just about to actually tell everyone. Thank you very much.
Right,
God, I thought my wife was very good at directing me on what was going to happen next. I didn't realise that you were as well. So look, you know, in getting back to the paper, this is part of the consultation process. This is our comments voiced today are part of that consultation. Will go back in as part of that consultation response, along with all the others that have been received. That will go to the whole consultation response will come back to this committee in November, which will be chaired by Mrs. Seaton. in my absence, and then finally all of that will go on to Cabinet for a final decision towards the end of November. So thank you very much for all the comments, and thank you very much for the participation on that item, because I know obviously it has been generating a fair amount of correspondence over the last couple of months. So thank you very much, Sally, as well as Mike. So we're now moving on to item 9, which is the public consultation, proposed changes to maximise access to health services for the local community in Lutterworth. So we have joining us, we have Sarah, who's Chief Statutory Officer for the ICB, and we also have David Williams, David, who's Group Director of Strategy and Partnerships, Leicestershire Partnership, NHS Trust. Yes, by all means, please join us at the front, and then we know. Otherwise, you get confused with councillors, which will never be healthy. So thank you very much for joining us. Musical chairs going on. So look, as usual, as you've probably heard me say at the beginning of the previous item, we'll take the report as read. Thank you very much for that. We also obviously had additional questions from Juliana under item whatever it was, 2. If you can pick up any of the follow-on questions that she raised, that would be great. Otherwise, hopefully you'll be able to respond directly to her. If you don't have answers directly today, that would be really helpful. Otherwise, we will then, once you've picked up those points, we'll then go into any discussion or any further questions. So who's going to be leading from your side? Sarah, well done. Over to you. Thank you.
Thank you and afternoon, everybody. So I will take the paper as read, but there's just a few things I'd like to pull out. And as I go through these things, I'll try and pick up those additional questions, and we'll provide you a full answer to those, Ewan, and you can send them out, can't you, for us? So we're here today to discuss the ICB's intention to go to public consultation to enhance services at Fielding Palmer Hospital in consultation on changes, to services at Fielding Palmer Hospital, which is in Lutterworth. I would say over the past year to 18 months, we've done a considerable amount of work developing a healthcare plan for Lutterworth, particularly in light of things like change in need, the change of service models, the things we've seen that have changed since COVID. And in particular for Lutterworth, there is a huge housing growth happening over the next 15 years in that area, with a considerable amount, about 7,000 or 8,000 new residents coming into Lutterworth. So we need to plan for that. The plan centres around providing more services locally, particularly around diagnostics and outpatient appointments and minor procedures in an enhanced procedure suite. And that was one of the things that was asked by Juliana, and the sorts of things that will be done in those that enhanced procedure suite are things like day case procedures that can be done quickly without a general anaesthetic and don't need any significant recovery time. We'll provide a list of some of the sorts of things in the full written answer. And the 6 additional clinic rooms that she's talked about, I will need to double check that, but there will be a mixture of outpatients, diagnostics and the enhanced procedure suite, together with some community services that LPT provide, such as community nursing clinics, podiatry, those sorts of things. And I think there is a full list in the business case, but we will provide a list as part of the supplementary answers. And the proposal also includes the closure of the current inpatient beds. I just want to say a little bit about the inpatient beds. Since the pandemic, the inpatient beds at Lutterworth, which was 11 beds altogether, 10 rehabilitation beds and 1 end-of-life care bed, have been closed due to infection and prevention issues, which are not going to be able to be solved in the future either, because those infection and prevention regulations are staying. During that time, we've also done a considerable amount of service redevelopment, and there are alternative pathways to beds, with the majority of people now leaving hospital going home through our Home First model, which we work closely with the County Council on, and our various discharge pathways as well, with a few patients who do need rehab going into alternative community hospitals close by. It's important to remember that pre the pandemic, there was only, although there was 10 beds in Fielding Palm, there was only ever 1 to 2 patients who were Lutterworth patients in those beds. So we've developed a pre-consultation business case to support our proposal, which has been supported by the Clinical Senate, the East Midlands Clinical Senate, which is part of the process that we have to go through, and NHS England, and is due to go to our board in October. In developing that, the proposals, we've built on insight, like Juliana mentioned, from public consultations that we've taken previously, but we've also involved key stakeholders in our working group, and they've included local clinicians, local public, and our various partners who are providing services in the new building. We're now looking to go to formal consultation because it is classed as a significant service change, which will start in October and last for 12 weeks. The consultation itself has been co-designed with local stakeholders, and I think that's detailed in the paper for you. And also in the paper describes the activities that we will be undertaking during that formal consultation. That's described in paragraph 37. In terms of the funding that Juliana asked, the 5.8 million is money that's coming from the local capital plan. It's not reliant on national processes, so it will be a local process, and that has been identified within our capital planning going forward. The criteria will be the process that the PCB is going through. So we'll go through formal consultation, and then at the end of the formal consultation, we will make a what is called a decision-making business case, which will reflect on the information that's come out of consultation with final proposals in there. So we're seeking support to our approach to go to formal consultation on those proposed changes. Have you got anything you wanted to add, David?
Thank you. Good afternoon. I think the only thing to add is the evidence of need that Sarah just talked through there based on information that we'd had from engagements and consultations. The evidence of need is also based on our own NHS analysis of where patients are going for treatment at the moment. So we know the LE17 patients, we know where services they're going to get, and therefore we've tailored outpatient appointments and clinics based on the needs that people are going to get that through. That's all I've got to add, so thank you.
Yeah, that's very helpful. Thank you very much, and thank you very much for the responses as well. Can I open up for any questions? I've got a feeling, Mr. Hill, Dr. Hill, Mr. Hill.
Thank you, Chair. What are these specific actual proposals physically for the site? Because it sounds like it's in a pretty poor state right now, this hospital, barely being used. Are we knocking it down and building it back up?
I'll pick it up. So no, we're not knocking it down and building it back up. What we are doing though is proposing complete refurbishment inside with an extension. So that an extended side to provide the enhanced procedures suite, a remodelling of the space that would enable the clinic rooms and the ways of working. What we're also looking at doing is saying, can we create some more space in a refurbished upstairs area that would enable community teams to have it as a drop-in base. And one of the advantages behind that, while that isn't patient facing, at the moment our community nursing team uses a base for Lutterworth out of Wigston, and actually if we can provide more local space for people to connect in, actually it's just across the pathway to the GPs, there's a better, people will be able to work in the longer area for longer. So it's a refurbishment with an extension to get us an enhanced procedure suite, the outpatient clinics, and better space for staff to be able to work.
Perfect. And are you going to be able to refurbish it well enough to get around these cross-infection control problems?
Yeah, essentially the big infection prevention control issues are around inpatient care. So by removing the inpatient care and providing enhanced procedure suites and other ways of working, they can do. The simplest way of summarising the building was the East Midlands Clinical Senate's review that for its current purpose, it is not fit for modern healthcare of inpatient care.
And then since COVID, you've not been offering inpatient care. I know you said there's only a handful of people that were using it anyway, if at most. But what's the impact been? Has that caused any major problems at all?
No, because as I described earlier, we've at the same time done a redesign of our offer. So lots of people, when they're being discharged from hospital, go into our Home First offer, which is a combined service with LPT and social services, isn't it, I think, which provides care in people's homes to support them for a number of weeks. Or where people can't go home, they tend to go into a care home or a nursing home if that's needed. And where there is a requirement for rehabilitation for a short period of time, there is sufficient capacity in alternative hospitals for that to take place.
Perfect. And then these 17,000 new appointments and tests, is that a net increase or would that be taken away from other places?
That will effectively draw from acute sites. So some of it will be from UHL to stop people having to travel, but some of it will be repatriating across the borders from places like Kettering and Coventry. Not Coventry, Kettering, isn't it? Sorry. My geography was all over the place there.
So there will be a little bit of pathway that does go to Coventry. There's a bit of a pathway that goes towards Rugby, and there's another bit that goes towards Nuneaton. But I mean, the simple bits, and you'll be aware of the travel info and everything, we'll be able to reduce the amount of time people from in and around Lutterworth spend travelling to their hospital outpatient appointments. And I think the public transport bus from Lutterworth into just Leicester city centre is over an hour. So it's those sorts of things, plus significant amounts of patient mileage that will be changed and stopped. So we won't have people driving into the city all the time, or equally over to Rugby and Coventry and Nuneaton.
And I'm not actually a Lutterworth member. I come from Hinckley and Bosworth. And I bear the scars of the CDC centre in Hinckley and how that's taken years and years and years to get to where we are right now. And what's the timeline for the future? Obviously, we're discussing the consultation today, but if the consultation goes well and you get really clear feedback, where are we going from here?
So, I think we are, I haven't got the timetable in the front of my mind at the moment, but I'll get it sent to you and so you can see it. I think we're talking about a year, aren't we, from now before we start building?
Consultation closing mid-January 2024. Decision-making process follows through. That will take us probably through with a full business case, and then you're into the kind of conversations around planning, ways of working. You could probably start making changes in March, April 25.
I think it's important to note it's a local process though, so we're not reliant on NHS regional or national processes for this business case, which obviously shortens the process.
And the final bit was about the money involved, because there wasn't cost in there, but I think Juliana said it's 5.8 million that's being spent. This sounds like quite an ambitious and impressive project. But I think I'm right in saying the Hinckley site is slightly different because they were knocking down the Hinckley Hospital and rebuilding it. But that was in 15 to 18 million range. So this doesn't actually seem like that much money for all that work.
Yeah, there's two costs for the Hinckley. One is the CDC, the Community Diagnostic Centre, which I think is about 22 million now, but Ratchner's not in. And then the day case re-provision, which is about 7.5 million. So it is different because it's the knockdowns and starts again, but Hinckley is considerably more, but there's considerably more activity going into Hinckley because it's taken a bigger catchment area.
I think that's it for my questions.
Thank you very much. Mr. Harrison.
Thank you, Mr. Chairman. The comments on Chapter 18 are really quite saddening for me in lots of ways, because I'm a big believer and supporter that there should be some beds. We're talking about people travelling and making life more easy in the modern world, but not to have that, I just wonder why, because it seems so sensible to have some form of accommodation where people can visit aging relatives or people who are really fairly ill, or as you put here, terminally ill. So that's a concern, because really you reflect back on the old cottage hospitals that no longer exist, but communities have really lost that ability to be able to go and see people instead of travelling and trying to find battle car parks and then journey through a hospital somewhere to actually see somebody. It's not a really good process, and I'm just wondering how futuristic you are working on that, because it's something that I believe passionately, that the more we can keep things local and the more people can have access and contact, that's really good in my mind. The other thing is it's wonderful and you're spending 5.8 and getting on with it as the NHS does. But what will this do for waiting time lists? I'm not able to see any glorification that, you know, this is going to have a fantastic effect now on waiting times for this and that and everything else. So that's something I'm mindful of, because when you say the upstairs is going to be used for already people out in the community doing things, and it just seems to me as if you've got a building now and you're just finding more and more usage for it, which will be cost because, you know, eventually you'll have a secretary up there or somebody else. The whole thing just seems to grow. It's got its own sort of natural growth pattern. So that's something I'd always ask, you know, so what are you going to do about that? And is there a reflection, or is this just an indulgence to make life a lot easier for those people working there? How is it benefiting the community? And particularly my first comments, because that's a disadvantage to the community. Your comments was there's only average of probably 2 people locally. But you've also now told me there's going to be thousands of more homes. So that community is going to grow. So there's my points. Thank you.
Thank you. Those questions are really helpful. We'll add a little bit of description and understanding and take you through those. So a vision about using the building is about how do we create a health hub. So on that Lutterworth site, we have the GP practices and we have currently Fielding Palmer. And the opportunity about creating a health focus there, which would then connect very easily with the East Lutterworth development, which is the access road from the East Lutterworth development into Lutterworth town, is going to go past the health hub. So we're going to create a focal point where people can come and access healthcare all in one place. I don't think we are looking at having a building and then going, oh, what do we need to do with it? If we take the community teams at the moment and think about the connections, if they're leaving our base in Wigston at the moment, coming down into Lutterworth where they're completing some clinics for the morning and then going back to Wigston as a base to check back in again, coming back out again in the afternoon, actually we're currently increasing their travel time and their ways of working. If we provide a touchdown support from there, actually they'll be more efficient. They'll be able to work in and around there. You talked around the cottage hospitals, and I understand there. What I'd probably describe is the concept of the cottage hospital is it describes care that is close to home, and modern healthcare is actually an awful lot more care in a home. And that's the difference of how we've shifted and how we're moving services. So many, many more people are now going home for all their care. We're able to complement that with things like virtual wards. We've got a really high, I think we'll see some changes in September, something like 86% of the bed space we've got on virtual wards is now being full by managing patients in their own homes using technology and other ways of supporting people. So the offer is very different to a traditional cottage hospital bit. Part of the advantage you get by being in your own home rather than in a smaller community inpatient perspective is actually you get to live your life better. You decompensate because you're sitting in a bed in a cottage hospital in a community facility. You don't walk about, you're not moving around your home, you're not making a cup of tea. Actually your muscles weaken an awful lot quicker, particularly the older and frail you are. So keeping people at home I think is a really good bit. And the other point you just mentioned was if Lutterworth is increasing, what do we do around the beds? The Lutterworth population is increasing, but it's going to be increasing with younger adults. So it's going to be younger adults and families. It's going to develop. It's going to need a greater number of outpatient appointments. It isn't going to see that corresponding bounce in the elderly population. And in fact, if we look at Lutterworth, once the East Lutterworth development completes, we'll see that the proportion of older people will decrease because of the new people coming in. So we've tried to pick up a model that picks the needs for the future population as well.
I just wanted to make a point about waiting time. So there are a lot of things that we're doing to support the decrease in waiting times. This will be a small part of that. So additional capacity will support a shift in waiting times, but it won't be the major thing that makes that change. There are lots of other things that are going on that will do that. So it's more for me about providing that local provision for ongoing need as opposed to necessarily tackling the waiting times. We've got other initiatives that will do that.
Well, what I'd like you to do is explain the initiatives. It should have been in our report, because then we can understand. Because what you have to realise is, as local members, we communicate with the public who have concerns, and waiting lists and treatments are always a regular comment from the public to members like ourselves. And so that's bound to always be at top of a list when we talk to members, people like yourself providing services. Waiting times are always there. Now, the answer I've had, Mr. Chairman, is, well, we're doing this and we'll build a block here and we'll do this and we'll do that. But what really is going to be the benefit? Because this is a massive cost. The whole thing's costing nearly 200 billion a year, and we just want to be able to go and see a doctor quicker and get a treatment quicker. Thank you, Mr. Chairman.
Thank you very much, Mr. Howson. Are there any other further points? Mrs. Season.
Thank you. I just want to confirm that the funding is there, or is it reliant on the consultation? It is there already. So this is something that can go ahead. Okay, thank you.
Okay, thank you very much. Okay, look, we've run out of questions in that case. Thank you very much, David and Sarah, for joining us. So I think Sarah mentioned about the consultation, and David, you talked about sort of the end of the consultation period. So we look forward to seeing this going out to consultation. I'm sure you'll get plenty of responses, and hopefully those responses will help to refine the proposition, and when eventually it hits site, as Mr. Hills discovered at tail end of next year, all hell will break loose on site, and then what comes next will be wonderful. So thank you very much for joining us, and look forward to hearing about the progress of the scheme. Okay, thank you. Right, we now move on to item 10, which is the health performance update. Got Andy Brown, team leader here at LCC, who's joining us. We've also got Rachna, who's joining us as well. Good to see you again. And Alison is online. She is. I can see Alison's name on there, AB. So, Alison, I think if you want to unmute your camera,
yep,
and then
I'm here.
Oh, no, you're.
Yeah.
Are you there?
Hello.
You're there, right? Okay.
Oh, here we go.
We can see your screensaver. We couldn't see anything else. Okay.
All right.
Thank you very much. So Alison is NHS Midlands and Lancashire Commissioning Support Unit. So hopefully three of you can actually help us on the health performance update. Who's going to be leading through any other questions? Andy, you sort of you're there. We're going to take the report as read, but if you can pick out any of the sort of highlights or things that you have spotted that you think should be flagged, and then raise any of those points, that would be great. And then we can ask plenty of questions. I know already from points that members have raised through the pre-brief that I think there will be a fair number of questions coming out about some of the performance items. So, Andy, you're going to start off.
Yes, just 30 seconds in context to hand over to Rachna and Alison in terms of the ICB performance. The report before you today, it's our regular performance report. You'll be familiar with the style of it. It's based on data that was available in August. 4 key bits to it: now ICB and ICS performance, and some changes are happening in the ICB world and reporting, and that's flagged up later in the report. I'm sure that'll be picked up. But also focus on some of the key areas the committee has raised in the past, particularly around UHL, never event, serious incidents, also positive progress that's flagged in the report, and then separate bits around the public health strategy and performance metrics and reporting, which I'll pick up later, and then just a quick update on the Better Care Fund plan, some new targets and reporting around that. So just to hand over to Rachna and Alison.
Thank you, Chair. I'm afraid I'm on last minute sub this afternoon, so please bear with me. One of my colleagues is unwell today, so I'm here in his stead. So what you have in front of you is the ICB report this month from a health performance perspective. I've asked to highlight just a few key bits, if you would indulge me, Chair, please. So we've got a series of benchmarking reports now, which we have access to on the NHS analytics data. It is, however, broken down only into what you used to know as the old clinical commissioning group areas. So we can get data for East and West Leicestershire, for example, but East Leicestershire includes Rutland, and we are at this point in time unable to disaggregate those, but there is work in progress to get some of that done. So from a benchmarking perspective, we do have further access to NHS benchmarking and a tool called Model Hospital, which also helps us when we're looking at specifics at a hospital trust level for both UHL and LPT, and that helps us to figure out where we are against some of those areas. So just from a highlight report, as Andy said, we've got quite some detail in the report about where we are against the NHS oversight framework, which is what we are reporting to you today. You'll know that we, the NHS, are held up for 31 performance indicators as per the NHS mandate for this calendar for this financial year. And what we've started to do is to report against those. And we've had quite a bit of interest actually at each place level. So for Leicestershire, for Rutland and for City through these scrutiny commissions, which has actually been very helpful to disaggregate some of that data. So that is all expected over the course of the next 8 to 12 weeks as we begin to unpick the many years of historical CCG data that we have to enable us to figure out where to focus for each of the places. Chair, open to any questions. As you said, we've taken the paper as read. Thank you.
Thank you very much. Okay, I can see Mrs. Newton's hand up first. So, Mrs. Newton, do you want to go first?
Thank you very much. Some very good work you've done here, and congratulations in terms of what you've been doing. It says you're the top quartile for this metric of people. This is people resident who were in acute hospitals. But I just wanted to ask a question again. How confident are you that we will actually meet the target of long-term support needs for older people and then going into residential or nursing home?
Chair, would you like me to collect questions or answer?
I suspect probably answer on the basis I suspect they're all going to be very, very different.
Thank you for the question. Actually, this is one that we're really very proud of. So you know, since the advent of the Better Care Fund, the local authority and particularly with our social care colleagues in the NHS have been working with our providers, as Sarah described in the previous item, on something called Home First, which enables our particularly our frail population, but generally our multi-morbid population, once they've had an acute episode of care, to make sure that we assess what those patients need to get them re-abled, so not just home, but re-abled so that they maintain independence. And you can see the figures there that people who remain home 90 days after discharge remains very high for us across Leicestershire. Yeah. And it's something we are genuinely proud of because we know it impacts on not only the person who's been in hospital, but also their family, their carers and so on and so forth. We've maintained it through every winter as well, actually. So you'll see in other areas, you get an ebb and a flow through the year. We are fairly constant, actually, in Leicestershire. And I'm very proud to say that's part of the partnership work that we do across the system, with a particular focus on the person and not the agency that should be dealing with them.
Thank you very much.
Okay, thank you very much. Can I ask one quick question, actually, before we go on to Mr. Charlesworth? I think in previous meetings, we've talked about being able to not necessarily looking at the figures in pure isolation. So obviously looking for Leicester and Leicestershire or looking at UHL's data is very, very interesting, particularly when it's against national targets. But what we don't necessarily always get is a feel for how we're performing locally within the region. Now, the one area where that's obviously not the case is actually in A&E admissions, where we're actually seeing comparison with other A&E centres sort of surrounding Leicestershire, where obviously residents can also go. that doesn't sort of paint a particularly healthy picture for UHL in comparison to some of those areas. And it does sort of lead the question, well, how are we performing on some of the other criteria compared to our near neighbours? I was just wondering whether in future we can actually see the comparative data for our near neighbours, because the A&E figures are interesting.
Chair, so particularly on the urgent emergency care pathway, we've done a significant amount of work with our regional colleagues. You'll know a company called KPMG, NHS England work with them, has only just finished work with them on some regional comparisons, particularly on the urgent emergency care pathway. So actually we've got more data now than we ever had on that benchmarking, and I'm absolutely happy to share a summary of that. What it showed, as you said, from a 4-hour wait perspective and a 12-hour in ED perspective, we benchmark poorly against our regional comparators. However, on things like discharge, particularly patients going home, remaining at home, and particularly patients who are going home with in-home support, which of course is provided by my adult social care colleagues. For those things, we are actually national exemplars. So not only are we the best in the region, we're in the top 10 in the country for both the quality metrics and the quantitative metrics that we measure. So it's a broad picture, but Chair, more than happy to share a summary of that.
Yeah, that'd be great. Because I mean, look, it's as we've said in previous meetings, it's great to actually see where we're doing extraordinarily well and potentially leading nationally, but also likewise understanding some of the local issues and some of the local pressures. So I think the more we can actually get on comparative data, particularly locally, because I mean, for most of us, we have the option of actually, getting referrals to hospitals outside of Leicestershire, particularly where those of us that sort of live on the fringes have that capacity of sort of ease, and therefore it'd be useful when we're talking to residents to be able to actually say, well, actually UHL is performing particularly well against other authorities or other areas in relation to X or Y. So that'd be really, really helpful. Mr. Charlesworth.
Thank you, Chair. It's important to follow on from that because we had the discussion this morning. Not just comparative data with neighbouring or authorities, but also comparative data for yourself. I mean, it's very difficult to know the direction of travel with these figures. So if we can have some previous data for you, it would help us tremendously. I mean, the devil's in the detail, and I know we can get bogged down. It probably end up with page after page of coloured charts and stuff. That wouldn't bother me. Chair will say if it's too much or not, but maybe there's a portal we can go to where we can look at all this kind of data. But certainly we need a bit more in front of us in terms of detail. Thank you.
So there are portals that you can access. It's still public data that we have to put into the public domain. So we can certainly send you the links to those. I won't lie, they are very cumbersome and you have to work your way out how to navigate them. But once you've done it, it's actually quite simple to get the information that you want. As you would imagine, Chair, we have plenty of longitudinal analysis on this data. If there's one thing that the NHS is very good at, it's collecting this level of data. So we usually compare ourselves to the last 24 months. So we do have 24 months worth of data for the majority of our indicators, and that, as I said, is largely on those benchmarking websites. We will provide the link via you.
Suspect we're about to be swamped by data, but if you don't ask, then that's it. We deserve everything that's going to come to us. Okay, Mrs. Seaton.
Thank you. Just referring to page 36 with the A&D. And noticing the other ones, you've got root causes, why the percentage is the percentage it is. But with the A&E, there's no root cause on there. Obviously, that analysis is done, and you've got a list of what you're going to do to solve the issue, but the root cause of the issue isn't there as well. I imagine they're very varied. But if you could just tell me what the root causes are.
Thank you for the question. As you've alluded to, it is a very complex system that we're working in, and that's partly why we don't put all the detail in here. When I look at particularly what goes through A&E, it's effectively three things. It's the number of people that we've got in the department at any one time, and that does impact on the amount of processing capacity that you've got for in any kind of business. If we were to run it as a business, which of course we don't. So there is the amount of processing capacity. The second thing is we have significant amounts of patients at the moment who are waiting in the emergency department because we don't have enough beds. We don't have enough beds necessarily or flow to sustain that patient flow. So patients wait longer in the emergency department, which counts against the 4-hour wait. And the last thing effectively is we've got patients in our beds who we know we could do something different with. So David, who was here earlier, was talking to you about things like virtual wards and Home First. Our focus absolutely needs to be on making sure that every patient who doesn't need to be in that acute trust is just not in the acute trust, but serviced at home in the place that they call home in the way that they want to be. And that's really that's the majority of our focus has been on that. We will always have people turning up to an emergency department that's in the city centre. That's just going to happen. No matter how many times we ask people to use services appropriately or provide services appropriately, that is going to happen because of the nature of geography. Our job is to make sure that every patient who phones 999 or 111 and seeks help is sent to the right place, and where possible, those services are in their own home. And that's our goal for this winter. So you'll see an inordinate amount of effort this year has gone into particularly things like virtual wards. You'll have heard of same-day emergency care, which is away from the emergency department, making sure people have got access to diagnostics and tests to keep them away from that department. So that's the gist of what we're trying to do. And it's mainly down to overcrowding in the emergency department at any one point.
My father-in-law is in a virtual bed, and he loves it. He doesn't have to travel anywhere, and he's monitored and well cared for. But at no time did you say about the staffing levels. Is that a problem at all?
So looking at pure workforce figures, and this is just workforce figures because I obviously don't work in the department itself. Looking at the workforce figures that are reported, we actually have one of the best workforce numbers for the emergency department since we built the new ED. So when we built the new emergency department, you'll remember we had a big recruitment drive, and we've been very successful at getting that department staffed. So based on the paperwork and the assurance that we receive, it is not about staffing. It is about process and flow and capacity to just the sheer number of patients that we have on a day.
My other question was going on to something else. Can I move on to that? So you've got the on page 13, no, it's not page 39. It's for cervical screening that you've got there on the bottom of page 40. And it's a vast age comparison you've got there. It's between 25 and 64. I would like a little bit more data on that to find out what section of the population is not being is not coming forward to be covered on the cervical screening, and is there anything specific that we could do about that?
So one of this is Councillor Richardson and I have this conversation regularly. This is the screening for me is one of the things that we should be absolutely excelling at. When we're talking to our population and when we're listening to our population, particularly those women who are not coming forward for screening, we generally get 2 or 3 themes of why people are not coming. Number one, you're running clinics 9 to 5 and I work 9 to 5 and I can't get there. Number two, they're run centrally and therefore not in my local place and I can't afford to, or I can't get to where I need to be to get the screening. Or number three, I'm just scared. And those are the 3 things that we absolutely, as a health and social care economy together with my local government colleagues, should be tackling. So you'll see plans now for, we've got screening out in local communities, in local community centres where the women are telling us that they can access. We've got access to clinics at the weekends and those types of things for people who work. And there's far more information now, less so in big public campaigns, but given to women about things like what to ask for when you arrive at cervical screening if you are nervous or you're scared or you're worried about the screening process itself. Those 3 things will help us, but it will only take us so far. So we've got plenty of the data about where people are coming for, which postcodes down to LSA level and so on and so forth, which we are happy to share. But any support from the Scrutiny Commission in your own local areas would be most welcome.
Well, that was going to be my next question. I'm on the PPG at our local Silverdale Community Surgery. Is there anything I can do, suggest to them to be able to alleviate this?
So we have the cervical screening and generally cancer screening programme, actually, which we have launched from our health inequalities work that we do in partnership with our public health colleagues. There is plenty of information that we can share with those PPGs to make sure that you are then disseminating that information. We've got new information that we want to put on people's websites, particularly general practice websites. There's lots of things you can do through your own social media feeds. So absolutely happy to share that, Chair, through you and perhaps the links themselves so that you can make the choice about what to put where.
I think using the members is very important because we do write things in local publications that different populations look at and read in a different way, so than rather listening to the radio or watching the television. So something like that would be very helpful for us. Thank you.
That would be most welcome, and not just for cervical screening, of course. You've got bowel cancer screening and everything else that we want to do.
Thank you very much. Can I ask one quick question? We're talking about staffing levels, Mr. Richardson raised. Can I ask about the strike action? I know it's been flagged in the report, which is how is that now impacting on some of the targets? How is there any mitigation that's actually working? And what are the relationships like, particularly with at UHL?
So the majority of the industrial action at the moment, of course, is having an impact on our elective side of things. So particularly our weights for elective care and cancers and those types of services. Thus far, again, we've worked in partnership across the health and social care economy to mitigate any risks as far as we can. Our general practitioners have stepped in to support our junior doctors or consultants, depending on who is taking action, have supported each other. So thus far, there has been an impact. We've mitigated it as far as we can by doing things like making sure we've had clinically prioritised cancellations and those types of things in place and agreed through the medical director at UHL, the medical director at LPT, and the medical director over at the ICB. So where possible, mitigations are in place, but of course it will have had an impact on those, particularly on those waiting lists.
Very much, Mr. Richardson.
Yeah, just on your point, Brenda. Just to be aware that we have had discussions about communication and everything through. Now we're all part of the ICF, and I think we all agree that communication has got to be better. But I have also been pushing how the role of a lead member within all of this, because we are very much in touch with all our communities. So just to confirm.
Very much. Okay, look, I think we've probably exhausted questions. I mean, we are genuinely, more data is always welcome. I always, succinct reports to guide us is great, but sort of access to background data, I think, for those who are particularly interested, is always welcome. So thank you very much for the offer on that. Any closing remarks, or are you quite happy with where we've got to on the questioning?
If I may, Chair, whilst I've got the floor, we have, as I mentioned before, we've got 31 performance indicators that we're measured against as through the NHS mandate. This is probably the first time that in my career, certainly, that I've seen movement on some really historic issues like IAPT, so accessing psychological therapies. We've kind of just kept it stable for the last 3 or 4 years. We've seen an enormous uptick, largely as a result of consultation and engagement with our local communities. So the new menopause pathways, the new pathways for people who are waiting on waiting lists, those types of the feedback that we are getting from our local communities is that they asked for something, we've listened, we've put things into place, and those services are really well received. And one other thing I would just draw your attention to, particularly from a mental health and wellbeing perspective, of course, we've had our mental health and wellbeing cafes, which have been launched, which have been inordinately successful in terms of not just the numbers of people that are coming through, but the amount of signposting that's happening. You were talking about your local area coordinators just before in the previous item, but it's that real localized knowledge about what people want, the types of information people need. And, in those mental health and wellbeing cafes, they're not talking about mental health directly. They're talking about the cost of living crisis and fuel poverty and access to schools and those types of things, which means that we can then spread across our public sector agencies, not only the ask of what our communities are saying, but we can actually start to tackle some of those systemic issues. So it's all about partnership, as Scrutiny knows. I say that every month whenever I'm here for any item, but I genuinely believe that working together across that public sector is helping now to move things forward in a way that we haven't seen before.
Brilliant. Thank you very much. On that uplifting note, we better end. Thank you.
And we bring Alison in.
Alison, would you like to say 2 words, even if they're goodbye? I don't know.
Bye. Goodbye. That's 2 words. No.
Look, we've appreciated you being here anyway. I'm sure the really, really tough questions Rachna probably would have passed over to you.
I have made a note and we'll support Rachna through and through in terms of the report. Yeah, and make it sort of more pertinent to the delivery of the 31 metrics, really. So you'll probably see a change in that report in 6 months' time.
Excellent. Look, thank you very much. We appreciate your time. Andy, likewise, thank you very much. Alison, Rachna, thank you again for attending. Okay, take care.
Bye-bye.
Right, thank you. Right, we'll now move on to item 11, which is noting the work programme of the Leicester, Leicestershire and Rutland Joint Health Scrutiny Committee, which is taking place next week. This is really for information for this committee. We haven't previously published the areas that have been covered, but I thought it would be useful for members who aren't part of that scrutiny to see what is being discussed. So you can actually see what's being covered across our scrutiny and also the joint one with the city and also Rutland. So date of the next meeting is the 1st of November. As I said before, Mr. Seaton will be taking the chair. I will be in sunny Sydney. So item 13, any other items? There have been none brought to my attention. So I declare the meeting closed. Thank you very much. Thank you.